Okay, there we go. Hopefully everyone can see that. So yeah, today's webinar, smoking and COVID-19. And look, a big thank you to Grant, who Grant usually asks to see my slides, which is always a good idea. And I'm going to put this up front because there's a bit of jargon in here, and I tried hard to get around it, but there are some things that I thought that you might like to hear about. If you find it completely boring and irrelevant, you can just switch off towards the end, but I've tried to cover some of the important stuff up front. So my apologies if the going gets tough right throughout. So anyway, just to recap on coronavirus, you all know, I'm sure you know this, there are viruses that cause common colds, and this one in particular can cause more serious disease. So this all started in December 2019, and this was a completely new virus that was unknown before the outbreak that began in China. There's a whole lot of terminology here, and you'll see different things in different text. The virus itself, of course, is SARS-CoV-2. So SARS is the severe acute respiratory syndrome part. The CoV is shorthand for coronavirus, and the 2 because it's the sort of second one. We had the first wave of SARS some years ago. Now, when this was first discovered, the first terminology actually was 2019 nCoV. So that was the 2019 novel coronavirus that the World Health Organization subsequently renamed to COVID-19. So this is shorthand for coronavirus disease 2019. So that's the one that you'll see most often. But remember, COVID is technically the disease caused by coronavirus. The virus itself is SARS-CoV-2. So it's little things, but of course, most people just refer to this as COVID or Rona or Corona or a whole lot of different things. But that's what we're talking about. Spread, and this is important for anyone working in clinical services or coming into contact with respiratory droplets, because this is primarily how it's spread. Respiratory droplets generated through coughing or sneezing in particular, but singing also can spread the virus. We saw those cases in the US with choirs singing, maybe singing at the top of your voice, and you've got virus particles being generated through the movement of your vocal cords. You can also get transmission via touching contaminated surfaces. So these are the formites that you get and you pick up and then touch your eyes, nose, or mouth, the so-called T-zone, eyes, nose, mouth. And that's where the virus can spread as well. And it can survive on some surfaces for some hours. Paper doesn't survive so long on that, but on some surfaces like stainless steel, it can survive for a long time. The good news is it's killed by disinfectant, so wiping surfaces down is a good way to protect yourself and others against the spread. Masks, I think I'll come on to masks again in a minute. One of the things that we were saying very early on, and it's because we didn't know a lot of the data at the time, was we didn't need to use masks. Now masks suggest, or the use of masks is a good way of not eliminating the virus itself, but reducing the spread. And you see some countries are very good at wearing masks. We, like the UK and perhaps the US, not so good. It's not one of our routine behaviours, but it's something that we need to get into the habit of doing. And hands up, I'm not very good at it either. I mostly carry a mask around in my jacket pocket. Symptoms, just the common symptoms: cough, shortness of breath, fever, sore throat, loss of sense of smell is another one of these symptoms. They typically appear some 10 to 14 days after exposure. And of course, having these symptoms doesn't necessarily mean you have the infection with SARS-CoV-2 or coronavirus. There may be other causes of these, but the bottom line here is if you do have symptoms, that you should get tested. That's one of the best ways we have to look after everyone. And some simple measures, of course, which you should all be doing in your routine practice, such as washing your hands often, avoiding touching your face, good cough etiquette, social distancing, and within your own household, you know, avoiding sharing items if you're unwell. And above all else, stay home if you're unwell. We still have this culture of, oh, I'll be okay and I'll come into work with a few coughs and splutters, but you see soon that this virus is very easily transmitted. So if you're unwell, stay home. Grant, I think you asked me this one. Is COVID just like the flu? Look, we're learning a lot about this as we go along. And initially, we didn't think it was so much different than the flu, or even thought that actually common flu still kills more people. That's not quite the case. So this is just a graphic from Vox I pulled off Google, which clearly shows a difference between influenza virus and COVID-19. So if you start at the very beginning looking at of how infectious the virus is, and you might often see this RO number, which is just an estimate of how many, if you've got one person with the virus, either flu or COVID, what's the average number of others that would be infected. So with the flu, it's 1.3. With COVID, it's somewhere now between 2 and 2.5. So not as infectious as something like mumps or measles. Measles up around 16 to 18. But still, 2 to 2.5 people for every one person that is positive for COVID is worrying. The incubation time varies.
Sorry, Hayden. Would you be able to use your cursor and just hover over the data? That would be great. Thank you.
So this is what I was talking about here. Thanks, Grant. This is sort of an indication of how infectious the virus is. So COVID is more infectious than the flu. Incubation time varies. So this is the time from exposure to first symptoms. With the flu, you get a pretty quick turnaround. With coronavirus, it's much longer. I said sort of on average that most symptoms appear within that 10-day period, but there's a range, of course. Hospitalisation, there's greater hospitalisation rate overall for coronavirus versus the influenza virus. You can see there 2% versus 19%. And here's the case fatality rate. So this is the proportion of deaths among all those with COVID or the flu. Now, overall, you might say, well, here we go. Here we have flu of 0.1% or less. Of course, 0.1% of a large population is a large number of people. But you can see here with COVID, it's somewhere between 1 and 3.4. And this is changing as we know more about it. You probably, of course, know that there are some people who have been infected with the SARS-CoV-2 virus but don't show symptoms and so don't get tested. And so the case fatality rate has sort of come down a little bit from it did at the beginning, because we're putting in more of these people without symptoms. But still, I think you'll agree that this is maybe up to around 30 to 40 times higher in COVID than it is in flu. So there is certainly a difference in the case fatality rate. So
do they know?
Not like the flu.
Do they know why people get it and don't show symptoms?
I think you get this with so many viruses. It's just partly that just your body's way of responding. There are going to be a lot more younger people that don't show the signs or the symptoms, or you might get people that just go, oh, I've just got a little bit of a runny nose, that's nothing. So there have been a few people reporting tiredness, for example, and they've had serology testing which shows that they have been infected, and they'll look back retrospectively and think, oh yeah, maybe that period where I was so tired was actually because I had COVID. But at the time, no one thought about doing anything about it. Mm. So there's a number of reasons there. So what can you do in your service? Now, obviously, you know that you need to keep on running as normal, and COVID's going to be with us forever. I don't know how long. I don't have a crystal ball, but I know I've been talking about probably at least 2 years or so before we might have a viable vaccine. We might be lucky, it might be here earlier, but I think we'd best be prepared to be in this for the long run. We've been lucky in Aotearoa. We haven't had the devastation that we've seen in other countries, but we're going to see these waves, and I'm not quite sure how long we'll hold out in the safe zone that we are in at the moment. So I think best we plan and plan for some pretty interesting times ahead. So thinking about your service and how you can maintain your service, because people are still going to want to stop smoking, but how do you do that more remotely? I think some simple things, screening for symptoms. Make sure that when you're booking people in or they're calling you, if you're seeing them face to face, screen for those respiratory symptoms. You know what they are. You can ask any cough, cold, sore throat, runny nose, head cold, loss of sense of smell. And if you've got those, they have those symptoms, then don't see them face to face. Continue on a phone call or via a virtual medium, a platform. Maintain protective measures, so making sure you have good hand hygiene, cough etiquette, posters to remind people to do those sort of things. These are behaviour changes that we all get good at it when we've got local spread or these cases like we've had in Auckland. We all go back to it, but as soon as it becomes quiet again, we all revert back to our normal behaviours. If you're having to be in close contact with people, so certainly if you can't maintain a distance of 1 metre and it's for more than 15 minutes, you probably wear a mask if you're in those close contacts. And look, to be honest, the homemade masks are quite okay for sort of the social masking. It's really just to certainly protect against people coughing and the aerosols going everywhere. If you are using homemade masks, then a sort of triple layer is said to be better. So having 3 layers in there, and there's plenty of YouTube videos. The WHO has one with someone making a mask and what to put in it. Adopt working with Zoom or DoxyMe. I know I use DoxyMe. It's free. You do have to sign up, but it's free software. It's secure software, and it's a little bit easier than Zoom. You just text people a URL, and at an agreed time you say click on that, and it opens it up into a web browser. So you could be on any web browser, any device, and that seems to work pretty well. Some of my colleagues at Manakiora are using that as well and quite enjoying it. And then infection control with your CO monitors. Obviously, if someone is sick, they shouldn't be coming in to see you anyway. So that should be one thing less to worry about. But of course, CO monitors, because people are blowing into them, there is a risk of contamination and transmission. So some simple things. Don't let the client hold the monitor. So you hold it and pass it to them. I know lots of you do this anyway. Bedfont do have some new mouthpieces called one breath mouthpieces. They are a bit more expensive than your typical mouthpieces that you use with that D tube. But you might, if you've got a bit of extra cash, or maybe you're operating and you have to do a breath test because you're using it for incentives, you might want to think about perhaps buying some of these one breath mouthpieces. You can have a look on the Bedfont website, which I've listed at the bottom of the screen. And of course, getting into good practice of wiping down the monitor with a non-alcoholic, and that's important, and antibacterial or antiviral wipes. So there's a few things to think about, and I know that we don't always do those things, so it's a little bit of behaviour change for us as well.
Hayden, can you explain the difference between a one breath mouthpiece and standard mouthpieces?
The one breath, as I understand, is you pull out everything in one go, so you don't have to have that D piece anymore. That's the bit that sits in the carbon monoxide monitor. But they're quite new to me as well. I had a look when I was looking into this. So have a look at the website. They'll explain a little bit more about those. Okay, here we go into something that's a little bit more complex. And again, feel free to switch off if you don't want to know about this. But this relates to how the virus gets into the cells, into the respiratory cells of the respiratory tract. But it also is related to smoking and the risk of getting the virus. So this is all about explaining whether smokers are at increased risk of getting the virus and are more likely to have a more severe disease, or maybe that they're less likely. And there's some data both ways. And we're learning a little bit about this as we go along. But the way that the virus enters the cell is via an angiotensin converting enzyme. Don't worry about any of this terminology, but it's in the system. And this system's really used for regulating blood pressure, for example, but it's also involved in inflammation. And some of you might know people that have high blood pressure or are using what's called an ACE inhibitor. And these blood pressure medications sort of act at this enzyme in reducing the activity of this enzyme, which converts one protein to another. And it's this protein here, angiotensin 2, which causes vasoconstriction. That's narrowing of the blood vessels that increases your blood pressure. Okay, that's enough on that for now. Let's look at this angiotensin converting enzyme number 2, because it's relevant for COVID infection. Okay, so this enzyme, if I just go back, has an action on this particular protein. Okay, so it limits the effect of this protein. So this is a protein found in lots of cells, but it's in the respiratory tract. As I mentioned, that this protein here, ACE2, helps control or break down the effect of the protein angiotensin 2. So it reduces blood pressure and it can reduce inflammation. But it's this receptor for this particular protein that the virus gets into cells on. And you can see it here in this picture of the virus attaching to this particular receptor, and it gets taken up into the cell. Okay. Whilst the virus does that, it also takes in this receptor as well, so it prevents the protein from doing its normal job. This will get a little bit easier as we go through. Okay. So what? So what about this? Well, it's the amount of this protein that's important in the disease process. So if you've got a reduced amount of ACE2, and that's because the virus is occupying the receptor, okay, with this, then there's less of this protein to break down that angiotensin 2, which means more inflammation, which means more severe illness. So this is where it all might, flow along. That's all a bit of a chain reaction. And also, you could say that actually it would mean more high blood pressure as well as more inflammation here. Now, smoking. There are data to show that smoking and nicotine exposure increase the expression of this ACE2 receptor. Now, that might sound initially bad to you because you say, well, okay, if smokers have got more of these receptors, does that mean that there are more of them to bring those viruses into the cell if you're unlucky to get hold of to be infected with the virus? And this is what we were initially thinking. This sounds bad for smokers. But there might be some other things as well. So there have been people talking about smokers, of course, are more likely to have that hand-to-mouth action. So that may contribute to additional risk. Disadvantaged populations, they're more likely to smoke, but they're also more likely to live in crowded households. So maybe that might be more risk of getting COVID in those who smoke. I've also seen people say, well, actually, because you're inhaling super hot air, maybe that kills the virus. And so maybe smokers are less likely to get COVID infection. So there's quite a lot of evidence, to and for and against this. But I think, to be clear, to date, there's no real definitive evidence here. So this is kind of nice to know, but just treat it with a little bit of caution. Now, some clever people have looked into this already. So this is a systematic review of a whole lot of studies that have looked at infection with SARS-CoV-2 virus. So they've been tested positive for COVID by whether they smoke or don't smoke, have never smoked. So current smokers versus never smokers here. And what you can see here, here's seen these forest plots before in some of my presentations. But what you're seeing here is that current smokers have a lower risk of testing positive for COVID than never smokers. And although this is pretty close to 1, but this was a significant difference here. So smokers were at lower risk than never smokers of testing positive for the virus. If you look at ex-smokers versus never smokers, there's no difference. So there's something about current smoking that seems to be coming up as important here in getting the virus. And risk of hospitalization, again, no difference between current smokers. You can see here, this little distribution here is crossing 1, so there's no significant difference here between current smokers and never smokers in terms of risk of hospitalization. So kind of curious, isn't it, that these data seem to suggest that there may be some sort of weird protective effect. Now this is terrible, but I'll talk you through this because this is some recent data coming from the UK, from England, with a cohort of 8.2 million participants from general practices in England. Now, this particular study was looking at the impact of taking ACE inhibitors. Remember the antihypertensive, the blood pressure lowering drugs that I was talking about at the very beginning. And they were, again, when all this happened, when COVID broke out, there was a concern that those on ACE inhibitors might be more at risk because actually they sort of generate more of these receptors that I was talking about. And so with more of these receptors, there might be more risk of getting infected with COVID. And actually what they found in this particular cohort was that if you were taking an ACE inhibitor, then you were less likely than if you weren't taking an ACE inhibitor to test positive for COVID. Okay, so that's quite nice to know for those of us who are on ACE inhibitors. You're certainly not at any increased risk, and these data suggest you might be actually a little bit protected. Now, that's not to say that everyone that's not on an ACE inhibitor should go out and ask their doctor for one. So just treat this with a bit of caution.
Or start smoking.
Now I'll take you down to the smoking. Now this was an unexpected finding here, but what they did is they compared infection, the chances of infection to never smokers and ex-smokers here. And you can see if you were a current smoker, either light, moderate or heavy, you were less likely to test positive for COVID. So again, here's another bit of information that suggests that somehow that smoking might be protective. And on this side is the risk of being admitted to an ICU. I'm afraid the benefits of ACE inhibitors go, but curiously, you see the smoking stuff coming up again, that actually if you were a heavy smoker, these confidence intervals all cross over, so don't take it with a pinch of salt. But if you're a heavy smoker compared to an ex or never smoker, you are less likely to be admitted to ICU. So interesting. We don't know why this is. It might be all related to that angiotensin system, but there might be something else going on as well, maybe especially in terms of this admission to ICU. We do know, for example, that nicotine does have some anti-inflammatory effects. So one of the hypotheses is that actually maybe the smoking or the nicotine that you're getting might stop your immune system overreacting and causing a whole lot of problems that you get with big inflammatory response. We know that nicotine does have these effects. Some of you will remember me talking about a certain inflammatory bowel disease, ulcerative colitis, that they used to use nicotine replacement therapy for treating that disease because we knew that nicotine had some mild anti-inflammatory effects. But it's not all good news. So again, try and balance all of this because there are other data that show that current smoking was an independent risk factor for in-hospital death. And so maybe this is about that if you are unwell and you're smoking and you've got a whole lot of other chronic conditions because of your smoking, so if you've got heart disease, then you are more likely to have severe disease. So it's not all cut and dry here. It's not straightforward. And that if you smoke, you're much more likely to have smoking-related illness, and those with smoking-related illness are much more likely to have more severe disease and more likely to die. So just sort of keep that in mind. And just a quote from the WHO there that say exactly that. Smokers may also have lung disease or reduced lung capacity, which would greatly increase the risk of serious illness. So final words then about all of this. The data at the moment, I'd say, may suggest a protective effect of smoking, but there's a lot of uncertainty about these associations. So know about it. Some people might mention this to you, but some caution is still required there. I think still the best bit of advice there is that if someone who smokes, the best thing they can do for their own health and, of course, the health and well-being of others around them is to quit. There are a number of people that have quit throughout the COVID response. So, just simple things of getting out of, lockdown to go and buy your cigarettes has been challenging for some. So be there to support them to quit smoking completely. That's the best thing. And we'll do our best to keep abreast of emerging data and let you know how things change over time.
So Hayden, why do you think it is that when the lockdown came, New Zealanders reacted really, really well, and most people, stayed in. They kept to their bubbles. They did everything correctly. I'm assuming that's because they were worried about the risk of catching this virus, and so everyone did pretty much everything they were supposed to. But with smoking, which has way more risk, people they continue to smoke. You know what I mean? So they're very risk averse with COVID, but they still continue to smoke. Why is that, do you think?
Yeah, the risk perception is a really difficult thing. And as humans, we're not very good at this at all. And we tend to respond to what's in front of us or what's been promoted as scary. Perhaps if you'd seen big media stories and every night it had the smoking update of who died and what they died of and how gruesome it was, then you might get less people smoking. But we tend to respond to what's right in front of us, and that sort of drives our behaviour. And picking up on your first point, that we were actually very good at changing our behaviours and sticking with what we were told, which was partly because of good leadership, but also very clear instructions on what we should do. And those alert levels gave us very clear instruction of what was right and what was wrong.
Is there any data that's come out around whether experiences with COVID-19 has increased quit rates, or have they remained the same? Quit attempts, sorry.
Yeah, the full data set's not out yet, and there is again a bit of evidence to the contrary. So yeah, there are some that show quit attempts went up, but others show quit attempts really didn't change, or people even relapsed to smoking because they were stressed. So it depends on the surveys and who was surveyed and what questions they asked. And so, you know, you've got some people, anecdotally, I know some people say, oh yeah, I went back to smoking because I was bored, or it was the only thing that I had to keep me sane during that lockdown period. And these periods of lockdown, as I think you all know, are not good for our mental well-being. And so having some coping mechanisms in place to help battle those is really important.
Well, should we hand it over to the group now for any questions that people may have? Have you got time?
Yep, sure thing.
Yeah. So if anybody does have any questions for Hayden, you can ask now, or you can use the chat function.
And these slides will be available, and they'll be up on the website as usual. You know, if it did become too confusing, you can always go back and have a look. But I don't think you need to have that full understanding of the mechanism, but just know that there are data that are suggesting that there may be some protective effect of smoking. Whatever that is, you know, it will remain to be seen.
Hopefully Donald Trump doesn't find out about it, or he'll have the American people drinking bleach and taking up smoking.
Yeah, and I think it's really important to remember that the risks of smoking, all the other risks of smoking, far outweigh any potential, you know, protective effect against coronavirus. Just to be really clear there.
All right. So.
Hello. Yeah, can I ask? Sorry, we don't have a camera at our work computer. So you can't see me, but I just with the smokealizers, yeah, so not to pass the smokealizer to the client, so that's mean that we're going into the 1 meter like personal zone, and then we have to have mask when we do that.
Yeah, if you're in a confined space for any length of time, yeah, I think that's a good thing to start wearing those masks. Remember, we sort of say 15 minutes has typically been that length of time, but look, if you've got masks to use, I'd use them.
Yeah, and the other thing is, yes, because I was thinking if I put it, the smokealizer on the table, then I don't have to wear the mask because I don't go close, you know, to the client. Yeah, and that I would have to, of course, but then it's coming into then you have to clean that before and after and use the gloves. Yeah, and with the mouthpieces, yeah, I still will have to wear a gloves to take the mouthpiece off, yeah.
Yeah, absolutely. And I think you should be doing all of those things, and just remembering that this virus is easily transmitted. And in this time of uncertainty, it's better to be on the safe side. It's really good infection control procedures.
Yeah, yeah. No, I'm just making that clear for myself. Yeah, you know, just with this PPE. Thank you for that, to reminding that. Yeah, thanks.
There's a question just about what about the risks of vaping? We don't know all of that yet. There are people looking into it. The data aren't so clear about vaping only because no one's collected. Well, there's more data collected on smoking than there is on vaping. It remains to be seen. It depends on what the mechanism might be. So, for example, if you're talking about if the protective mechanism of smoking was because you were inhaling hot gases, which killed the virus, let's say that was the mechanism, then that may not apply to vaping because vaping doesn't heat the liquid up to that sort of temperature. If it's a protective effect of nicotine, then one would imagine that would apply similarly. So I'm sure someone's doing some work on this at the moment, looking at vaping in particular. but that would be it. I think some general advice with this though, that don't share your vaping devices. Don't pass those around, because then of course you risk transmitting it. There's no data yet that I know of that's suggesting that or proving that the vapor itself can transmit the viral particles. So that was raised, but I haven't seen any data so far to prove or indeed refute that. What would you use to clean a CO monitor during level 2 restrictions after use? The same stuff, Maurice. It's just a non-alcoholic wipe. I think we just, from now until whenever, I think we just do this and make it standard practice, regardless of what level restriction we're in. I think the level restrictions are a little bit arbitrary, but I don't imagine that we'll eradicate the virus completely. And we know that we've got it here, it's just in different places. So I think getting into these really good behaviors of, no matter what level we're in, when we use a CO monitor, we give it a wipe down.
And it's also important not to use alcohol-based products on your CO monitor, because that can affect the sensors, and it will, it can destroy your monitor.
Has either sharing cigs or vapes been? No, Alberto, no data that suggested that at the moment, but that's always a possibility. One of the problems, of course, is that no one's really asked about those data. So in theory, I'd say, yeah, that could be a theoretical way of transmitting the virus. Yeah. So again, some good common sense advice, and we do that. In isolation. If you're in isolation, don't share your utensils, your cups, your other things. Keep them to yourself.
All right. Well, I think that's pretty much covered everyone's queries and questions by the look of it. That was fantastic, Hayden. Thank you for that. And sharing your time with us this morning. Very much appreciated. And thank you everyone for coming on board. And remember, if you've got colleagues who weren't able to see this, it's being recorded and it will be on our website sometime tomorrow. So back to you, Hayden.
Thanks very much. And we'll, next month, I'm not quite sure what we'll be talking about, but no doubt Grant or someone else will give me a topic. I think there might be actually some lined up, Grant, but we'll do this again in about a month. Until then, stay well, stay safe. Ka kite.